Hi, everybody. We are back. Our interviews continue.
Yep.
And next, we're going to start hearing about some of the very impressive work being done by the CHNC focus groups, of which there are, I don't know, there must be like 100 of them, but we're going to talk about a few of them in the next 48 hours. We have Charada Gowda and Jessica Fry joining us today. And now you guys hold many roles in the CHNC and in your institutions and in the neonatal community. I guess we'll narrow it down to tell us what you're each involved in as part of the CHNC.
So for the past several years, I think since something like 2019, I've been a co-leader for the Palliative Care and Ethics Focus Group, along with Kevin Sullivan from Nemours in Delaware. And recently we have another focus group leader, Ali Lyle.
So that's the PACE group.
That's the PACE group. It began life as the mortality subgroup.
Oh, wow.
I know.
That was our first that was our first order of business once we broadened our leadership. Rebranding.
And I must say, I think your group really, was a turning point, has been a turning point in the last, I'd say, five years on a new, renewed energy and focus on how palliative care is a specialized part of the work that we do in the NICU. So we're looking forward to hearing more. But that's not all you do in the CHNC.
No, I'm also a member of the fetal therapy focus group.
Okay. Tell us.
And I lead the POCUS, point of care ultrasound focus group, but here I'm representing the CDH. Just like you said, I do involve myself in a lot of the focus groups, but everything is mostly because I'm interested in hemodynamics and the cardiovascular aspect of it. And I feel like heart is everywhere. So I just need to put my little
your expertise everywhere.
Yeah.
Yeah, connections that the organ systems and our disease processes are not
and the way
in isolation. Yeah.
Focus.
Yeah, they're definitely not in silos. I think, in HIE, we just actually are, like, is ECMO something that we should do in HIE? Like, is it a contraindication? Or in CDH? So the reason why I started in CDH is really because of the left heart in CDH. Yes, I do like CDH in general because it is organ, even though we say it's just the heart, the intestinal or, in the chest. That's really not it. There's a lot more that comes with CDH. So I became part of this focus group because I really like the cardiovascular and the hemodynamic aspect of it. And so right now we're actually working on a clinical practice guidelines, a consensus guideline statement, because we don't have any. So if you look at anywhere, folks are doing, like, what vasoactive medication do you want to use in a patient with CDH? Okay, they have hypotension. Let's start dopamine. Is that the right medication? Or they have pulmonary hypoplasia, so let's just crank up the ventilator. But that's going to deplete the venous return. So then there's hypotension. Then we slap on the dopamine.
Yeah.
So really trying to streamline all those things is really what brought me to CDH focus group. And man, the learning has been tremendous. Like, it's really amazing to work with this group of passionate folks that have so much energy, so much intelligence, and I'm learning every day. I feel like it's just been a great.
But you highlighted an important thing. I think many people are part of multiple focus groups, and it seems like you guys are still able to do the work in a way that is manageable enough that people can get engaged in different things. I think especially, we were highlighting the trainees' involvement in the CHNC where maybe they haven't elected a part of study yet. And I think this is a way for them to really engage with a topic as they're trying to figure it out. So I heard in the CDH group, you guys are working on this clinical practice guidelines. Yeah. Anything else we should know about what you've been working on in the CDH group specifically?
Oh, we just published our outcomes data and the calculator, the outcomes calculator. That's amazing. So anybody who has access to CHNC platform and the dashboard can just go put in their variables and then actually learn how the baby might do. So it's really important for the both for the fetal therapy intervention group as well as for prenatal counseling, right? So we are going to talk to the parents, the future parents, about the outcomes of their baby, of the fetus, and the possible interventions that can actually lead to better outcomes, or if there is no intervention that we can actually do, like fetal or something like that, they also are empowered to ask more questions and then find out, is there another avenue that they can go or another institution that can offer, because not every institution offers fetal, and we do know outcomes of fetuses with CDH, with fetal, fetal occlusion of the trachea is actually better outcome if the window is optimized. So those are the things that we can talk to parents.
So really useful tool to look for.
Absolutely. Yeah.
And the two of us will be both part of an antenatal counseling workshop later this afternoon, designed to look at some of the innovations in fetal therapy and how that really adds a unique dimension to counseling. So my background is more in bioethics and communication, and yet that's really the neat thing about the collaborative nature of focus groups is you can be interested in something like this, come at it from completely different angles, and it really brings a broader picture and a broader look at some of these interesting disease processes and what we do every day.
Right. So like how you marry something like a calculator to the clinical practice of antenatal counseling.
Right.
What are the best practices in there? Right. And some of that depends on how you think about the calculator and statistics. So is not every family will be interested in the same sort of numbers.
Right.
Or the resources even, right? So not every family can just get up and go to Texas Children's because we offer aortic valve dilation or we offer the atrial stenting, but there are families that are ready to move, and for them that's the right fit. So if somebody at maybe Minneapolis knows that hey, Texas Children's is doing this, then they can give that parent that information. And options are always good because parents need to know what else is out there.
We need to standardize our offerings and then personalize it to the needs of the family.
Absolutely. And that's wonderful.
I think that's a perfect segue to you talking to us a little bit about what you guys are doing in the PACE focus group. And PACE stands for
Palliative Care and Ethics. So acknowledging that it's bringing together people from across different disciplines, again, all with a vested interest in studying sort of these really challenging dimensions of our neonatal care.
Right.
Because as much as we want to continue to focus on the improvement, for some families, unfortunately, the outcome won't be the successful outcomes that we're talking about today. So how do we optimize that?
Right. There's still improvement to be sought in that process.
It's just a different sort of lens for that improvement, exactly. And that's more how, many of us went into medicine. I think all of us went into medicine because we wanted to help. Sometimes the way you help is just different.
Right.
So our PACE group has been very successful over the last couple of years in doing some collaborative survey projects that we've really been very excited about. We had one now that was a few years ago, but was just published last month on collaborative practices across the CHNC between neonatologists and palliative care specialists. Where is there alignment? Where is there perhaps disagreement about things? And I think my big takeaway from that work is the more we collaborate, the more we work together, it just fosters an environment of that to the benefit of all. And we just completed a project last year looking at resources across the CHNC to support NICU staff at the time of patient bereavement. How do we prepare for that possibility? How do we, again, care for people who've just finished a shift and you've experienced a patient loss, and then you just have to keep going on? That leaves sort of a bit of moral injury along the way. So how do we support our teams in that process?
So a survey really designed for healthcare provider burnout, mental health, all of the really salient issues in that area.
Exactly. So that then we can show up and be our best selves for the next patient who needs us.
A lot of times these are not even at the end of the shift, right? They're happening. I remember actually compassionate extubation, sitting after a prolonged code, giving the mom her baby and sitting down only to run to another exit procedure where I had to be 100%. So this was an exit with a large airway malformation, and
Really
how do I
critical
actually,
situation.
yeah, so like I don't have time to think or like do anything other than be there 100%. So
So that manuscript is being written. But
Yeah.
our major finding
Yeah.
from that survey study was that the more resources individual sites have when a survey respondent knew there were more resources available at their location, they were more likely to be satisfied with the overall process of bereavement support. So they might not even utilize those resources, but if they know they are part of an institution that provides them, that matters. So maybe there's
Having
more ways.
options, having
Yeah.
options. What is the spectrum of resources that hospitals are providing for both family and professional support?
So it really varied widely, which is what you'd expect, right? Whenever you look at 52 centers across the CHNC, you come up with wide variation for all sorts of things. But everything from how do you think about education at the time that somebody's starting a new position, to what kinds of gift baskets might someone provide a nurse after the end of a tough shift, to thinking about time away, to memorial services, to morbidity and mortality conferences, right? There's so many different ways to conceptualize resources. And
different people probably gravitate to different types of resources in those scenarios.
and some of them are likely role specific too. Our study was actually very multidisciplinary. So we had physician, nursing, bereavement specialists, chaplains, speech therapists, respiratory therapists who participated.
That's quite a feat.
yeah.
One of the amazing, again, collaboration in the CHNC, we had 466 survey responses. So we had a really wide multidisciplinary group, which was awesome.
That's the power of CHNC is what I'm seeing.
Love that.
It takes a team. It takes a village here.
That
really
absolutely
does. It's the collaboration.
Thank
Oh my
you
God.
both so much for all of the work that you're doing, for coming and spending some time with us today, for following through with workshops and abstracts and disseminating all of the information that your groups are doing. We're looking forward to reviewing more of those manuscripts on the podcast as they come. So thank you for your time.
Thank you.
Hope
Thank you so much.
Conference.
Yes.
Thank you both.